Okay, I promised you 6 boxes, so here's the first box. Hit it again. First box is death. Hit it twice. You deal with, and you're going to see some information about life expectancy. We deal with infant mortality in public health. We get these death certificates. We try to figure out, what's happening in our jurisdictions around death. Sorry, planners, that's what we do. We're actually death watchers. Next slide. We have these documents, death certificates. Very useful documents because they can hit 4 times. They tell us 4 things that are very important to know about essentially the distribution of death in our communities. They tell us what somebody died of, how old they were when they died, what their race, ethnicity was, and where they lived. And you can take those 4 data elements and you can do a pretty significant analysis of the distribution of death in your community at any given point in time or over time to understand how death is happening. And most people in public health don't have an awareness that death is not randomly distributed. You will after this because we have a lot of data. We took 400,000 of these death certificates in Alameda County and analyzed them, and we've now been working with Chris Kippis and Terry to try to do some similar analysis in Cuyahoga County. We're going to show you some preliminary stuff. Next slide. Okay, first very simply, hit it one more time. The things that are killing people in Alameda County, this is the cause of death, are the same things that are killing people in Cleveland and Ohio and the state of California and the U.S. as a whole. It's chronic disease. It's heart disease, it's cancer, it's stroke, it's smoking-related lung disease, and it's injuries, but primarily cancer and heart disease. Next slide. Now, when you take 400,000 death certificates, you can actually do this analysis over time, longitudinally, to see how death and how life expectancy, the length of life, has essentially evolved in your county. If you want to go back in time before 1990, because you're dependent upon the census to be able to do this calculation, you can only talk about white and black and other, because the census didn't really talk about anybody else until 1990. So we wanted to go back as far as we could. We went back to 1960 reliably in Alameda County. We actually went back a little bit further than that. But the data started getting spotty. So we put together this analysis of life expectancy for white and black between 1960 and 2005. And what we see, what you could see obviously, is that life expectancy for African Americans, which is the lower line, is increasing. Life expectancies for white is increasing, but they're increasing at different rates. Hit it one time. In 1960, the difference in life expectancy in Alameda County between white and black was 2.3 years. In fact, in the 1950s, African Americans, according to our death certificates, lived longer than whites in Alameda County. But in 1960, 2.3 year difference, not much difference. Hit it again. 20 years later, in 1980, that gap was up to 5 years, and hit it again. And then in 2005, it's up to 8 years. So, despite what we think about our healthcare system, at least in Alameda County, this gap is growing. And it's growing on our watch. It's grown in my lifetime. And I consider it, although at times I wonder whether we ever get held accountable to this, I consider it my job to close that gap. And to close that gap by creating essentially somewhat of a measure of progress in the rate at which that gap is changing. And in fact, on my watch, this gap has gotten worse. So I should be fired, honestly. I really should be. If we lived in a system that was accountable, somebody would be saying, you know what, you're just not cutting it, and you're out. But I'm not fired. As a matter of fact, nobody ever asks me about this, despite the fact that it is the #1 goal of Healthy People 2010. #1. Nobody ever asks me. We had to ask ourselves. Next slide. We asked ourselves, well, what explains this? And, sat around in a room and people said, well, it's probably HIV. Oh, it's probably homicide. And so we said, okay, well, let's subtract out homicide and HIV and see whether it makes a difference. We did that in this analysis, and it makes a little bit of a difference, but not significant. This gap is driven by chronic disease. This is heart disease, this is cancer, this is stroke. These are the things that are killing everybody in Alameda County. They're just killing African Americans earlier and making them sicker earlier. Next slide. So in summary, with the mortality data, we know that we have a big gap in life expectancy that's growing, and we know that it's driven primarily by chronic disease. Next slide. Okay, so next box. The next, hit it again, thank you. So, I went to medical school. You don't have to be a genius to recognize that premature death is probably driven to some extent by premature disease. And so, hit it 3 times. We know that chronic disease, infectious disease, injuries are all driving this disproportionate rate. So now we're trying to figure out why this gap is growing. Hit it again. And the first question that comes up in a room like this, because this is what you do in public health. You sit in a lot of rooms and you say, here's my data. Why is this happening? And people throw up their hands and they say, this and that. Well, people throw up their hands and they say, well, it's genetic. Obviously stupid. I mean, these are white people and black people. They're completely different people. And, the genes have obviously been evolving, so that explains it. Well, I'm joking, but if you look at the literature would almost suggest that it has to be genetics, because the study keeps getting done over and over again looking for the gene that explains it, and it's never found. But NIH keeps funding the next study. All right, so what does the literature say? And again, genes might explain about 10 to 15% of the differential distribution of disease in society in general. However, genes don't equal race, as we all know. There's more variation within race than there is between races. So even if genes were, fully explaining the racial difference, which logically it couldn't, it would only account for 10 to 15% of that differential distribution of disease in society. So hit it again. So the next thing somebody throws up their hands and says, well, it's access to health care. It's the fact that they don't get to see doctors, and of course doctors deliver health, right? If the healthier society is entirely dependent on how many doctors that are in that community, right? Well, no, actually wrong. The literature says it again. Only about 10 to 15% of the difference in the disease patterns in society can be explained by differential access to health care. Now, there's probably 3, 5, 7 people in this room that disagree with me. Hit it again. Here's my literature. Where is yours? Because we've looked high and low. This is what the literature says, and I'll show you some other stuff from CDC later that says very similar stuff. So before you disagree with me, show me your data. Just show it to me, because I'd love to see it. Next slide. Okay, so next box. It's this notion of risk behaviors. And I went to Johns Hopkins Medical School and paid $100,000 to go there. Acquired a not insubstantial amount of debt. Nothing like the debt that people are racking up these days, but a not insubstantial amount of debt. That $100,000 taught me this about public health. That everything you need to know is about what people do to themselves. Hit it again, and again, and again. So it talks about the fact that the differential distribution of disease is due to the differential distribution of smokers in society, people who don't eat right, and people who don't exercise. And therefore our job in health and public health is to change what people do. And so we developed this sort of behavior change paradigm, which basically amounts to live your life like me, not like you, and you'll live longer. And I spent a lot of time in medical practice basically saying that. Basically saying, you know what, it's your fault. If you exercise more, if you smoke less, if you ate better, you'd live longer. So, take this pill and, come back and see me in 2 weeks. $100,000 for this education in public health. You've had it in 5 seconds, so you've got a pretty good deal. We also tell people to avoid violence when possible. When the bullets are flying. So this notion of individual health knowledge is basically what we need to do. Just lecturing people, do this, don't do that. It's pretty much what the public health paradigm has, unfortunately, become. And it evolved away from planning into this domain of individual medical model, hit it again, thinking.